Hi everyone, my name is Lori and thank you for joining us here at UT Southwestern Medical Center, where we are doing a series of Facebook live chats for Breast Cancer Awareness Month. And today we'll be chatting with diagnostic radiologist Dr. Phil Evans. Thank you for joining us today, Dr. Evans. We're really happy to have you. And I'd like to mention that Dr. Evans is the director of the Center for Breast Care here at UT Southwestern and past president of the American Cancer Society. So he works with mammography all the time, every day, and he's here ready to answer your questions. We also want to thank the Moncrief Cancer Institute in Fort Worth for supporting this chat. So don't forget to like and share this chat with your friends and put your questions in the comments section. We'll get to as many questions as we can. So let's go ahead and get started, Dr. Evans. Thanks for taking the time with us today. And I know you've worked with mammography quite a while, so I wondered if you could give us a history of how mammography came into use.
Well, mammography came into use many years ago, probably during the 60s. And that's when the first real mammography machines were developed. It's changed a lot. It's changed from initially film mammography to a process called zero mammography, which was the images were printed on paper with blue and white colors. And then it changed back to film mammography again in the 80s. And then digital mammography came about in the early 2000s. 2002 was the very first digital mammography unit. And one of the most recent developments has been tomosynthesis, which is sort of like a CT scan for a mammogram. And so that's one of the latest developments that's come from mammography. So it's changing all the time. It's changed throughout the years. One of the things that has not changed about mammography is the need for compression of the breast when a mammogram is taken. And that's always one of the issues that people want to talk about is why do I have to have my breast compressed? And the reason for that is because we get a better picture when we compress the breast. It doesn't have to be painful, but just enough compression to hold it steady and so that we can see through the breast tissue. And that's why we have to have compression when we do a mammogram.
Well, thank you for bringing that up, because I know that's a concern for some women. They want to know why it's painful, so that was a really good explanation. And can you tell us a little bit about how it came into use as a tool for screening?
Well, the first screening studies were done in the 1960s with mammography, and the New York Health Plan did a screening study, and they found that if all women got screening mammograms yearly during that period of time, that they could reduce their deaths from breast cancer. So that was really the very first study to ever show that. And subsequently, about 8 or 9 different studies have been done throughout the world, which have also showed that screening with breast cancer saves lives. The results of all those studies, the randomized control studies that were done, have shown about a 25 to 30% reduction in breast cancer mortality. One of the very kind of interesting stories about how those studies were done was people were invited to be screened, and so just an invitation counted as a screen. Some people that were invited didn't come, and some people that were not invited were screened otherwise. So it was those screening studies were really a mixture of people who were screened and not screened. But even though there was cross-contamination in all those studies, they still found a reduction in breast cancer mortality. When you look at the people who were actually screened during those studies and the ones who were screened, those are called observational studies, it was found that the death rate was reduced by 40 to 50%.
Wow, that's really significant. That's amazing.
That's right. And so it's really an amazing test that can do that. We've seen also in the United States in the last 20 years, actually since the early 1990s, there has been a 40% reduction in the death rate from breast cancer during that period of time. So this is really one of the most amazing stories that can be told about reducing deaths from breast cancer, the use of screening mammography. And in the United States, we only screen about 60 to 65% of the women in the country that are eligible to be screened. Wow. So if we screened everyone in the country that was eligible, we'd save even more lives. It's estimated probably another 6,000 to 7,000 per year.
Wow, that's really significant, and thank you for telling us all that information about how it got started and why it's so important. You know, many of us are aware of Breast Cancer Awareness Month, and we see all the pink, and we know we need to get screened, but maybe we just need that little extra push to actually go and make that appointment. So thank you. Do you want to talk just a little bit about the screening guidelines that you recommend?
Yes. We recommend the American Cancer Society screening guidelines and have for years. The very best way that you can be screened is, if you're a woman at average risk, is to have a mammogram beginning at age 40 and then continuing yearly throughout your life as long as you are well and able to have it done. There are some recommendations out there, particularly those from the United States Preventive Services Task Force, which came out just about the same time as the American Cancer Society guidelines came out, which suggests you could start at age 50 and have mammography every year between the ages of 50 and 74. We don't recommend that. Like I said, we recommend you begin starting at age 40 and continuing yearly. Now, one of the things that can be shown if you do that beginning at age 40 and go yearly thereafter is that many more lives can be saved than if you do every other year beginning at age 50. In fact, studies have shown that throughout this country, if you do the age 40, as we discussed, about 6,500 more lives per year will be saved. You'll miss about 30% of the cancers if you do it beginning at age 50 and do it every other year rather than doing it yearly. So that's why we recommend beginning at age 40. We think that's extremely important. And remember, that's for women who are at average risk, not women who are at high risk. We have different protocols for women that are at high risk of developing breast cancer.
Okay, thank you very much. And we have some questions coming in now, so I'm going to start taking some of those. One question we have from Rebecca, which actually refers to what you just mentioned, being at high risk perhaps. She said that her sister has stage 4 metastatic breast cancer, and she'd like to know what screening method is best for her. She's had mammograms in the past, and she's 58 years old.
Well, a lot of that depends on when your sister developed breast cancer. So we look at first-degree relatives, and first-degree relatives that were premenopausal are the most important. Also, the thing that we consider is genetic testing. For the first, when the breast cancer genes mutations were first discovered, there were really 2 breast cancer genes that were found. Now we have multiple other breast cancer genes that can be looked at, and genetics has become an extremely important part of what we do. People who have family histories of breast cancer or see it in their families, first-degree relatives are the very most important. First-degree relatives means a mother, sister, or daughter who's had breast cancer. Premenopausal breast cancer is also very important in doing that. So if there is a concern about what a person should do who has a family history of breast cancer, the thing to do would be to come and get a consultation at our high-risk clinic here at UT Southwestern. We can refer you to genetics if genetic testing is necessary, and recommendations can be made based on your risk. It's important to know how high the risk is. Women who have a lifetime risk of greater than 20% generally are screened with both mammography and MRI. Those are our 2 major screening tests. If the risk is between 15 to 20% a lifetime risk, then we may screen with mammography and ultrasound. And lower than 15% lifetime risk with mammography alone.
Thank you very much. We have another question now from Crystal. She'd like to know what is dense breast tissue and how is mammography different for those patients?
Well, when we look at a mammogram, when the radiologist looks at a mammogram, there are really 4 stages of density that we see. Some breast tissue is completely replaced by fatty tissue, and so it's very easy for the radiologist to see that breast through the breast on that tissue. It's like looking through a clear window. Other breast tissue is very dense, and there are 2 stages that are not so dense two stages that are dense. And looking through dense breast tissue is almost like looking through trying to see through a forest. It's hard to find something in the forest. It's hard to see the animal or the cancer in the forest like you would on a mammogram.
Okay.
So that's what dense breast tissue is. People who have dense breast tissue, we generally recommend a new examination for them, which is tomosynthesis, which allows us to see through dense breast tissue more easily. We also may recommend ultrasound as well, which may aid us in seeing through dense breast tissue. So those are two additional tests that may be used in women who have dense breast tissue.
Okay, well, thank you very much. And we actually have a question that's just come in about dense breast tissue. A woman who's almost 32 and does self-exams, has 2 boys that she's breastfed. She says, when should I get my first mammogram? I have lots of dense tissue.
Well, generally speaking, if you have no family history of breast cancer and you're at average risk of developing breast cancer, then your first mammogram should be at age 40. The incidence of breast cancer is much lower below the age of 40 than it is above the age of 40, and that's why we recommend starting at age 40. That's not to say people don't get breast cancer below the age of 40, but it's much less common. And for average risk people, we don't screen for breast cancer until they're at age 40.
Okay, thank you. So we have a question from Heather who would like to know, what are the benefits of a 3D mammogram? Can we talk about that a little bit?
Yes, we sure can. Like I said, the 3D mammogram is a relatively new technology. We helped develop that here at UT Southwestern and help the first manufacturer get FDA approval, along with other academic medical centers throughout the country. The 3D mammogram allows the technique to take slices of breast tissue that we can look at individually rather than combining all the tissue together for just an overview. We generally take a 2D mammogram, which does show the entire breast, and then we take a 3D mammogram, or tomosynthesis, which allows us to see different slices through the breast tissue. And in many cases, you can find cancers on the 3D mammogram that you can't see on the 2D mammogram. In fact, it's been shown that you can increase the number of cancers you find by about 40% on the 3D mammogram. So it's a very useful technique, and we use it just as much as we can at UT Southwestern in terms of people who have dense breasts, and we use it for people who don't have dense breasts because it's been shown to find more cancers in breasts of any density.
That's really fascinating. That's a huge difference. Thank you. We have a question from Jennifer who would like to know, what can you tell us about thermography versus a traditional mammogram?
Well, thermography first came about in the 1980s, and there have been many different types of thermography during that period, during that time, and on even now, thermography keeps popping up. Generally speaking, thermography is something that should not be used for breast cancer screening. It is not effective and does not find breast cancer early. It finds breast cancer late. So it should not be used for early detection of breast cancer.
Well, thank you. And we have another question. So I think people have a lot of questions about different types of technology and equipment, and this one is from Heather. She says, in terms of updated equipment, is there anything that people should ask about when they're looking into choosing a radiology facility?
Well, you should always ask about when your equipment has been updated. How new is it? Do you have tomosynthesis at this facility? Do your radiologists use high-resolution ultrasound? Is your facility capable of doing breast MRI? And so these are some of the technologies that are used. Are there any other new technologies that you may have at your facility that could be used? It's very important that the technology be up to date, and it's the highest level of quality should be used. One of the greatest things about mammography in this country is the fact that we've had accreditation programs that are mandatory for most mammography facilities, or all mammography facilities in this country, that are used by the American College of Radiology. Testing must be done, and data must be shown that the mammography equipment is good. And so it's very likely that most mammography facilities will be very high quality. Some are better than others, obviously, but most must meet the minimum standards of the American College of Radiology.
All right, so now we have a question from, I hope I'm pronouncing your name correctly, Gia, who says intraoperative 3D specimen imaging versus 2D. What are your thoughts on those two?
Well, that's something that's been useful, I think. But 2D mammography has been used for many, many years for specimen radiography, and so far it's been a great technique. There is a possibility of using a 3D specimen radiograph, but so far I don't know of any studies that have shown that there has been an improvement in the intraoperative specimen radiography. Just so everybody will know what we're talking about, when surgery is done on an individual who has a breast abnormality, a specimen radiograph or specimen X-ray of the surgery specimen is taken to determine if that cancer has been removed or that abnormality has been removed. Mm-hmm. And so there is a possibility of doing just a regular X-ray of that, or doing a specimen 3D radiograph of that. So it is sometimes with small lesions it may be helpful to do the 3D radiograph, but usually the magnification images are so good you can see what you need to see.
Good, thank you very much. And Gia actually has a second question. She says, is cryoablation a safe alternative for tumors other than fibroadenomas when approved by your doctor?
All right, cryoablation is a technique that has been used for several years in the treatment of different kinds of breast tumors. It's a freezing technique is what it means. You freeze the abnormality, and by freezing it, you can make it disappear. It was first started doing benign tumors called fibroadenomas. And the freezing technique takes about 20 or 30 minutes to do. The fibroadenoma, in our hands, when we tried that, took maybe several months or almost a year to go away. Now it's being used in some centers in terms of trying to treat small breast cancers. And it has been used, like I said, and is found in some centers success. But, one of the real problems with that is if you do the cryoablation, you don't know where the margins are because you can't operatively see the margins of the tumor. The tumor would still have to be taken out to determine if the margins were clear. And so cryoablation by itself, I don't believe, is a very successful technique in modern day medicine for treating breast cancer.
Okay, thank you. And at this point, I'd like to remind everybody we have about 10 minutes left, and everybody's sending in such great questions today. Please continue to do so. We have some more time to take a few more questions. And I wanted to ask you something that came in before we started today, which was, is it possible for a mammogram to have a mammogram and that it misses your breast cancer?
Yes.
Does that happen?
Yes, mammography is, although it does find many breast cancers, it is not a perfect examination. And sometimes a breast cancer will be located in a person's breast in an area that can't be covered by the mammogram. Sometimes the tumor will be hidden by the dense breast tissue. So the sensitivity of mammography is generally about 85%. The sensitivity decreases with dense breast tissue, increases with not dense breast tissue. And so yes, there's some tumors that can't be found with mammography, unfortunately. So that's why it's important to have a physical examination, because many of those tumors can be palpable and can be felt, and not to ignore any lump that you might find in your breast, even if a mammogram is negative.
I'm glad you brought that up, because I was wondering if you could tell us a little bit about things women could watch for.
Yes. Well, we have many years talked about breast self-examination. Breast self-examination is really not recommended as a tool to decrease mortality from breast cancer. But it's just sort of obvious, that women should know what their breasts feel like, what the tissue feels like.
Sure.
And if you find something different or find something new on the examination, come see a professional about that, or your provider, have them examine you, have a mammogram, have an ultrasound, so you can find out what that is, because it's important if you have a change in your breast tissue to know what that is.
Sure, and then you have a record of it, right? So
Correct.
even if it's nothing, you know what it is.
That's right.
Okay, that sounds great. What about pregnant women? We have a question from someone who wants to know, is that safe to do a mammogram when you're pregnant?
Well, generally, we don't do mammograms on pregnant women unless they have a specific sign or symptom of breast cancer. In those cases, we do. You can shield the abdomen so that the fetus is not exposed to any radiation. But lactating women, we do examinations on lactating women if they have a sign or symptom of breast cancer that needs to do that. And we can also do ultrasound examinations on women who have breast cancer, who are pregnant as well.
Okay, well, that's great to know. Can you tell us a little bit about what would be the average age of a woman who's diagnosed with breast cancer? What age is at greatest risk?
Well, the statistics on that are really kind of interesting, because probably the fewest breast cancers occur in women between the ages of 40 and 49. But that's one of 6 breast cancers occur in that age group. Now, as you increase in age, as you move through life, I like to say, the incidence of breast cancer increases as you move through life up till age 80 or so, and then it begins to level off. So, but the number of breast cancers occur most frequently in women between the ages of 50 to 70. And so that's where most breast cancers occur. And that's where the highest number of breast cancers occur, because that's the greatest proportion of the population. Okay.
Still, 1 in 6 breast cancers are found in women in their 40s, you
that's
said,
right.
So that's pretty significant.
Well, the other part about that is that one of the reasons we suggest beginning at age 40 is not only are the 1 in 6 breast cancers found in women in their 40s, but because a woman in their 40s has many years of life to live, that's where approximately 30% of the years of life saved from all mammography occur in women who have breast cancer that's found early in their 40s.
Okay, and we have another question. This is about breastfeeding, which is also something that tends to come up. Does breastfeeding really offer you protection in terms of preventing breast cancer?
Breastfeeding is one of the things that decreases your risk of breast cancer. It's a small risk, but it does incur some small decrease in risk.
Okay, well, that's good to know. And I know before we started this chat today, we were talking between us a little bit about things on the horizon in this field that sounded really interesting. Would you like to tell us a little bit about any significant emerging trends ahead?
Well, other than the latest emerging trend, which is tomosynthesis, which is really gaining traction throughout the United States right now, one of the things that we're looking into is a different type of MRI to be able to help us find breast cancers and find them early. One of the things that we know about MRI is it finds more breast cancers than mammography, and it is the most sensitive test for finding breast cancer. The problem with MRI is that it's expensive, it requires IV contrast media, and it takes about 30 minutes to do an examination in most cases. We're working on a fast breast MRI technique where we can do an MRI in about 6 minutes.
Wow, 6 minutes.
6 minutes
That's
instead
amazing.
of 30 minutes. And get all the necessary images that we have so that we can find breast cancer and find it early. And it's also been shown in some cases that this can find a lot more breast cancer in average risk women. Most of the work with MRI has been done in high risk women because that's who gets it the most. But we're working on the fast breast MRI so that we can be able to do that in maybe the intermediate risk women as well.
Well, that's really exciting. Can you tell us a little bit about how long do you think it'll be before we start seeing that happen on a regular basis?
Well, it's just in the stages right now where we're beginning to start our protocols on that and testing how it will be done. So I think within the next year we'll probably have that up and running.
Okay, well, we'll be sure to watch for that. Thank you. And we do have one final question, and this is a common one. So the question is from Crystal, and she says, why is it important to not wear deodorant or antiperspirant during a mammogram?
That is a real good question. I'm glad you asked that. A lot of deodorants have metal in them, aluminum and certain other things like that show up on a mammogram like calcifications. Calcifications are one of the things that we see on a mammogram, which can be a sign of an early stage breast cancer. But if a woman wears her deodorant, it may show up the same way, particularly if it's on the breast, and it may be confusing and may be confused with an early stage breast cancer. So that's why we ask women not to wear deodorant when they come for their mammogram, because it will show up on the mammogram in many circumstances and be very confusing.
Sure. Okay, thanks for letting us know. And we did have one final question. We're about to wrap up, but we do have one more from Heather about the compression that a woman feels during a mammogram, and she wants to know, should I be concerned if I didn't feel like the life was being squeezed out of me during a mammogram? So she had one recently that wasn't as painful as she expected.
Well, no, you should not necessarily be concerned. It is important to have nice compression. When we do a mammogram, we say we compress because we care, and we care about the images that happen. But sometimes you can get a very good compression, and it's not really painful. Women have different degrees of tenderness in their breast, and some women have very tender breasts, and some don't. And so the degree of compression we monitor on the mammography machine, and we can tell if we get good enough compression. In some women, we may get great compression, and they don't have any tenderness or any pain at all with mammograms, and others may have very light compression, and because their breasts are tender, it may feel like they're very painful. So the mammography technologist will work with you to try to make sure they get good compression every time they do that.
Great. Thank you. So don't worry if it doesn't hurt. It's probably still just fine. All right. Well, thank you, Dr. Evans, for all your time today and
answering these
questions. We do want to thank Moncrief Cancer Institute in Fort Worth for supporting this chat, and encourage you all to like and share this with your friends. Do join us. We have 2 more chats coming up during Breast Cancer Awareness Month, and the next one is next Wednesday, October 18th, on breast cancer surgery. And thank you for joining us today.